Good morning, students. Today we'll talk about snoring and obstructive sleep apnea, which is slowly growing because of the lifestyle related problems, the increase in the obesity, and the lack of exercise, which induces muscles becoming weak. Sometimes there's a phenomenon called disuse atrophy. So the parts which are not used usually slowly degenerate, and so there are several people don't do their exercise, and so the muscles become weak. So these are the causes. The obesity is increasing, and the muscles becoming weak, and so with that brief introduction, we'll go to as the name suggests, the subject proper is obstructive sleep apnea. That means there is obstruction to the air passage. Usually respiratory system starts at the nasal cavity, at the anterior nares, then the nasal cavity, the nasopharynx, and then the oropharynx, the laryngopharynx, and then it just continues into the larynx, and then trachea, the bronchial tree, and the alveoli. So that is the respiratory passages, respiratory system. It starts from the anterior nares, and this part of the respiratory system, which is starting from the anterior nares to the larynx, is the upper respiratory tract, and from there it is the lower respiratory tract. So there is obstruction to the airflow for various reasons, which we will discuss, in the passage of the air into the larynx, and then further down into the trachea and the lungs. So let us try to slowly understand what the physiology of sleep. This is basically what happens is sleep is a recurrent kind of a phenomenon. Every day, night, you sleep, and sleep is the one which is usually manifested wherein you have all the voluntary muscles are slow, they are totally taking rest, and it's a kind of a situation wherein you become drowsy and your reflexes come down, semi-conscious kind of a state. So your reflexes are not very good. Your muscles, the sensory elements are poor, and you go into sleep. And the sleep is usually staged into non-REM sleep and REM sleep. In the non-REM sleep, you have the stages 1, 2, 3, and 4, and you have the REM sleep. Now, non-REM sleep is the one which is the major part of sleep, whereas the REM sleep is about 20 to 25% of the sleep. Now, what really happens in these physiologically in this stage 1 is something like drowsiness. you become drowsy, you have a tendency, your reflexes are dull, you would like to sit down and then sleep or relax. Then stage 2, wherein you go into sleep. Stage 3 and 4, there you go into deep sleep, and then as you go into the deeper levels of the sleep, the body reflexes, body sensory reflexes are slowly going down, and the response is poor, and you are not aware of the surroundings, that whatever is happening. And that is as far as the stages. And this they found by the studies by polysomnography studies, which studies the various waves that are generated during the stage 1, 2, 3 and 4, the alpha, beta, theta and delta waves. Okay. So these are the stages. Stage 1 is a light drowsiness, stage 2 is light sleep, and 3 and 4 are deep sleeps. And during this, the various waves are described, and so polysomnography is the method by which you can decide about the stages of the sleep, the various waves that are occurring. Now REM sleep is another sleep, rapid eye movement sleep, wherein there is the brain is active. There's a lot of brain is activation, but the patient, or not the patient, but the person is sleepy, and the reflexes are down, the sensory reflexes are down, and all the voluntary muscles are totally relaxed. So then, with this brief background about the sleep part of it, as I told you, the sleep 3/4 is the stage 1, 2, 3, 4, whereas the REM sleep is only 20 to 25%. Now, people used to think that sleep is the one which wherein the metabolic activity is down, and so that is the time when your totally regeneration takes place. But the basic metabolic rate comes down only by 10 or 15%. So there is metabolic activity is still on. With this brief introduction to the sleep and the levels of sleep, then we go to the another heading, which is called the snoring. Snoring is nothing but sound that is produced during sleep because of the muscular relaxation. As you know, one is the nasal cavity, the other one, if the nose is blocked or for whatever is the reason, the person can also breathe through the mouth. And so in the oral cavity you have the tongue, and the oropharynx you have the soft palate, the anterior and posterior pillars, the tonsils, the base of tongue, and the posteriorly you have the posterior wall of the pharynx, oropharynx, which is formed by the constrictor muscles, as we have discussed. So this is the area. This is the area which is soft and collapsible. The oral cavity, oropharynx, is the one which is soft and collapsible. So normally what happens is the air passes through the nasal cavity, and then just nasopharynx, and then it comes into the oropharynx. From there, that is the epiglottis. From there it goes into the laryngopharynx. That's normal. So there is no obstruction in the awake state usually in the normal breathing. That is what happens. But when you sleep, particularly in the supine position, the air passes as it passes through the nasal cavity or through the oral cavity. We have said the tongue is nothing but a muscular organ, and this tongue relaxes and falls backwards. and the muscles of the soft palate are also totally relaxed, and so the soft palate also narrows down the nasopharyngeal isthmus. This is called the nasopharyngeal isthmus. And so there is partial obstruction, and when there is a partial obstruction, there is an increased respiratory effect, and so air tries to pass vibrating these structures, that is the soft palate and the base of the tongue. And so that vibration which is produced by strong inspiratory the currents are the ones which vibrate and then produce the sound. And the sound that is produced is variable from maybe 10 to 15 decibels to 90 decibels. 90 decibels, that is the sound that is produced by severe snoring people. So, and as you know, 90 decibels is a decibel level which is discomfort, and if people are exposed to this kind of a sound continuously, like in the industry, some of the industries where there is a loud machine sound, so this is also similar, and so people have effect on the hearing. That is called sensory neural deafness, which can occur because of noise trauma, which is called noise trauma. So that is the severity in some people about the snoring and the sound that is produced, and the partner, either your wife or the husband, whoever it is, have to face this music all through the night when there is a person, one individual is snoring. And that is, sometimes if it is partial, it is called snoring, and this is a normal phenomenon which usually occurs in about 25 to 15%. 25% in the adult males and 15% in the adult females. So it's only basic sound is produced because of partial obstruction, and it prevalence increases with the age because the muscles become more flaccid and tissues are maybe hypertrophied, which also narrow the passage. Now then the snoring is a physiological. Most of the people have this, so there is nothing very alarming about this. But if it goes into next phase, is the sleep apnea. That means there is a total cessation of the breathing. And this cessation, if it is continuous for lasts more than 10 seconds during sleep, it is sleep apnea. And usually less than 5 such episodes, less than 5 episodes of sleep apnea are normal. Only they become abnormal if so this is what disorders of the obstructed breathing occur during sleep, and cessation of breathing more than 10 seconds is one is called the apnea. It may be hypopnea sometimes, and so there is decreased airflow, as you have seen in the partial obstruction, and then there is the decreased airflow obstruction, which is more than 90% airflow is diminished. Then that is called total apnea. So, and this apnea and hypopneas per hour are counted, and that is called respiratory disturbance index. So if this is once again a diagrammatic representation of the obstruction that is caused during snoring and sleep apnea. This is the mandible, the maxilla, and patient is in supine position, The tongue is attached anteriorly to the mandible, genial tubercles, geniohyoid and genioglossus muscle. Geniohyoid muscle and the genioglossus muscle. So that is the attachment of the tongue to the mandible, the posterior surface of the mandible. And when during sleep in the supine position, the tongue, instead of being like that, since it's a muscular tube, muscular organ, the entire tongue relaxes and falls posteriorly, thereby pushing the soft palate up and then narrowing the nasopharyngeal isthmus, and also it blocks this passage oropharyngeal and into the hypopharynx and then into the larynx. So most of the time the major culprit is the pharyngeal part, this is area where it is collapsible, whereas in the nasal cavity it is the bones, the cartilages, so the passage is usually clear unless there is some kind of abnormality. And lower down in the larynx and the trachea, unless there is some kind of a swelling or some kind of a tumors, inflammatory swellings, they may cause this snoring. But otherwise, this is the area where it is not likely. The commonest area we should stress is the oropharyngeal region, which is collapsible because of the muscular tongue and the soft palate, which is also muscular, and of course the epiglottis can fall backwards and then obstruct this passage. So this is briefly about the snoring, which is just the sound that is produced because the vibration of these muscular structures because of partial obstruction is something not very abnormal, which as we have seen about 20-25% of the normal individuals. So there is no need to be very apprehensive in such patients, such people. And the next one is the sleep obstruction, obstructive sleep apnea. OSA is obstructive sleep apnea. That means if there is obstruction for more than 10 seconds, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds. That is the time when total blockage or there is no breathing at all during such period. So that is called sleep apnea. And the apneic phases, if it is between 15 to 25 during the sleep time, okay, that is called mild apnea. If it is 26 to 40 times per hour, then it is called moderate apnea, and if it is more than 40, it is called severe apnea. So apnea is defined as 10 seconds of obstruction, total obstruction to the breathing. And if these episodes continue between 15 to 25 mild apnea, 26 to 40 is the moderate apnea, and above 40 is the severe apnea. Then and we have mentioned here the muscles of the pharynx are relaxed during sleep. The tongue falls backwards, and so as I told you, the sound may be as loud as 90 decibels, and that is what is the snoring or obstructive sleep apnea. Then we go to the various etiological factors. What are the factors which produce this snoring? Now, in children, it is usually the adenoids, very common, and these days the incidence of the adenoid hypertrophy is maybe increasing, or people are aware of this. And so, as the air passes through the nasal cavity, the adenoids, which are situated at the junction of the roof and posterior wall of the nasopharynx, there is a hypertrophy of these tissues, and so the air passage gets narrowed, and so that produces snoring in children. The commonest cause is the adenoid and sometimes the tonsillar region in the oropharynx that also enlarges and pushes the soft palate and decreases the oropharyngeal isthmus region. Then we go to the adults. Snoring is usually either in the nose in the form of various obstructive conditions, pathologies, which may be a deviated septum, see that, and sometimes the inferior turbinate or the turbinate's hypertrophy, or there may be a polyp inside, and this is similar, a polyp obstruction. These are the causes, some of the causes, or various tumors that are present in the nasal cavity can give rise to obstruction in the nasal cavity. And similarly, when you go into the nasopharyngeal region, you have the adenoids in children, and adults, some kind of tumors may produce this kind of a nasopharyngeal obstruction and cause snoring. Then we go to the oral cavity. After the nasal cavity and the nasopharynx, we go into the oral cavity. Sometimes there is a macroglossia. That means the tongue is bulky, and so that is one of the contributing factors. The tonsils may be enlargement of the tonsils because of inflammatory and hypertrophy, and sometimes the retrognathia, that is the mandible is receded. It's a congenital condition, malformation, and sometimes there may be tumors on the base of the tongue, and these are the causes which can give rise to obstruction in the oral cavity and oropharynx. Sometimes the elongated, hypertrophied soft palate and the uvula, and this is the one, the tongue, which is increased in size, which is called macroglossia. And on this you have the tonsils on the side, which are usually like that, but they may get hypertrophied and give rise to obstruction. So this passage becomes narrow, and so it may produce, or there may be tumors there in the base of the tongue, or sometimes maybe in the posterior pharyngeal wall or hypopharynx. So these are the causes for obstruction in the oral cavity as well as the oropharynx. Then if you go into the larynx, there is a laryngeal stenosis that may occur, and sometimes the epiglottis is curled, omega shaped, and then can give rise to, or flabby, and so these are some of the conditions in the hypopharynx and the larynx which cause the obstruction. And in children, sometimes the multiple laryngeal papillomatosis or some kind of tumors that arise in the larynx can also give rise to obstruction and give rise to snoring. So that is the larynx, the component laryngopharynx and the larynx. And inflammatory conditions like the acute tracheobronchial, laryngotracheal bronchitis, and the other causes, which are other causes, include obesity and a short neck. Obese people and with a short neck, all the passages are narrowed down, and so there is obstruction, obstruction to the air passage. And then the other factors usually, which is also growing habit, use of alcohol, sedatives and hypnotics aggravate snoring due to muscle relaxation. The muscles, as I told you, the tongue, the soft palate, they relax totally and then obstruct the oropharyngeal region. So these are the various etiological factors which produce snoring, starting from the adenoids in the nasopharynx. Then you have the nasal cavity, the various deviated septum, the polyps, and the hypertrophy terminates, nasal valve deformities, some kind of tumors. Then the oral cavity, these are the structures: the tongue, the soft palate, the uvula, and the tonsils, enlargement, laryngeal, and obesity. As we came to obesity, as we know, the incidence of obesity is increasing. It used to be maybe 10, 15 years back, maybe 2%. Now it is about 8% or so. So this, what happens is obesity. There is accumulation of fat in the abdomen, and so this there is this diaphragm which separates the lungs or the chest cavity from the abdominal cavity. So when the abdominal cavity there is fat deposition, obesity, and when you lie down there is pressure on the diaphragm, and so the chest cavity as such, the thoracic cavity, is reduced its caliber, and so this pushes and then reduces this, and so there is obstruction, and air has to flow at a inspiratory effort increases, and so when there is an inspiratory effort that increases, there is a negative pressure that occurs, and so there is collapse of tissues, and so that causes, sometimes people have short neck, and so the tissues are so hypertrophied in this region that the passage becomes very narrow. So obesity is one important condition which you need to consider in case of, and a short neck in cases of obstruction in the causing snoring. So these are the various causes of that you have enumerated, and so what are the symptoms with which patients usually come? A snorer usually doesn't come. His wife or the husband, whoever it is, complains and says there is so much of sound that is produced, and so they're taken to the doctor for consultation. The second one is excessive daytime sleepiness, because as I told you, there are stages in sleep: stage 1, 2, 3, 4, and then the REM sleep. And people who sleep light, they do not, the sleep satisfaction doesn't happen. It happens only when they go into the deep sleep, which gives them total relaxation. And if they don't go into this deep sleep, and they're light sleepers, because of snoring obstruction, there is a pathophysiology. Let's go into the pathophysiology of how this sleep occurs. Now, sleep initially, as I told you, the voluntary muscles are totally relaxed, and you go into a drowsy state, and your reflexes are down. During which time the tongue falls backwards, and the pharyngeal activity of the muscles, they become weak, and then airway collapses, as we have discussed. And when the airway collapses, there is apnea, there is complete stoppage, that is called sleep apnea. And after the apnea, there is hypoxia that is built up, and in the blood, hypercapnia occurs, and so this is the one which stimulates the respiratory center in the brain, and so suddenly you go into from a deep sleep, you go into a lighter sleep, and the arousal, you lighter sleep, and your reflexes are back again to keep the airway patent, and the pharyngeal muscles activity is restored, and so they keep the pharyngeal passage open, and so air is taken in, and hyperventilation happens, hypoxia is taken away. So this is the cycle. They sleep, neuromuscular compensation, decreased pharyngeal muscle activity, collapse, air collapses, airway collapses, apnea, total stoppage for more than 10 seconds, and the hypoxia, that is carbon dioxide built up in the blood, stimulates the respiratory system, and so the brain says there is some problem, obstruction, and so you go into a lighter plane of sleep. When you go into a lighter plane of sleep, there is the muscles, the pharyngeal muscles, they open up the air passages, and so the normal breathing occurs, and then you ventilate, and then once the oxygen concentration increases in the blood, and so they go into a deeper plane of sleep again. From stage 1, 2, 3 and 4 they go, and then same thing repeats. So this is the pathophysiology of sleep apnea. So we'll consider what are the various symptoms. One is of course the snoring, the sound that is produced complained by their partner, and because the sleep is not satisfied, so they have daytime sleepiness. That is very dangerous. And the morning headaches, because hypoxia continues, or several episodes of hypoxia occur, and general fatigue, memory loss, irritability, depression, and decreased libido, and increased risk of road accident because your reflexes are dull. You are tend to go into sleep, the drowsiness, and then into sleep wherever you are. So this is what happens, and this is how it is depicted: early morning headaches and daytime sleepiness and poor concentration, irritability. You're traveling and then somebody puts a brake and then you try to put a horn and then shout at that fellow, and then there is all sleep, and then the reflexes are dull, and then you tend to make an accident. Then you go in the night. These are the changes that occur: frequent visits to the bathroom, restlessness, you won't be able to sleep, totally go into the stage 3, 4 of sleep, and choking, and there are pauses in the breathing and snoring the sound. So these are the things that happen in the night, and these are the symptoms that are present in the daytime. Now the pathogenesis, same thing what we have discussed here in the pathogenesis of sleep apnea. How it happens is there is occlusion, same as I told you, the oropharyngeal isthmus, that is the oropharyngeal region is the one which is collapsible. Let me show you another diagram that shows okay, maybe picture is not there. Let's see. So these are the various diagrammatically. There's a diagram which says there are depression, there is memory loss, there is mental confusion, then you have weakened immune system, the blood pressure increases, the heart problems also increase. That is the one. Sometimes for severe snorers, sometimes they die because of the cardiac problem in sleep itself. Then you have the abnormal cholesterol, the fatigue, the muscles become fatigued because not enough oxygen going to them, the high blood sugar levels, low blood oxygen levels, and you have the liver problems, the breathing troubles, and the acid reflux. Okay? These are the various symptomatology or the complications that occur because of snoring. And this same thing is listed here: hypertension, daytime sleepiness, concentration, irritability. And this is what apnea, tachycardia, and during ventilation, sudden death during sleep may occur. So those are the complications. Now, if you go into the history, usually the history, they say there's a weight changes. They tend to put on weight. The growth hormone abnormalities, GERD, that is gastroesophageal reflux disease. Habits, sleep schedule is totally disturbed. And if you see the past medical history, there is hypertension and use of sedatives and antihistaminics. So the physical examination is the height and weight, the body mass index, neck size also becomes bulky, face retrognathia, that is the mandible going backwards, the nose, various obstruction, any obstruction in the nasal cavities as we have enumerated, the hypertrophies, deviated septum, and the polyps or neoplastic conditions. Then the oral cavity, the palate, uvula, and the tonsillar regions are the ones. Now, if you see the oral cavity, this is what a diagram is. This is the soft palate, the uvula. See how the tonsils are enlarged, grade 4, almost touching in the midline. And of course, this is the tongue, which is bulky. And so, see the oropharyngeal isthmus, which has become so narrowed down. So, this is what we find in the oropharynx. Now, with those physical examination, now we need to do certain tests in order to see the areas which are not usually amenable for ordinary examination. That is, we do a study called the fiber optic nasopharyngoscopy. That is, you pass a nasopharyngeal fiber optic scope, and then this is how it looks like, and then you pass and try to study if there is any obstruction in the nasal cavity, the nasopharynx, the soft palate area, oropharyngeal isthmus, the oral cavity, and then go into the epiglottis structure and the laryngopharynx and the larynx. So this examination is done by nasopharyngo-laryngoscopy. It's a fiber optic instrument. Then the other investigations which are helpful in order to find out what is the gravity of the situation are the electromyography, which tells us the muscular component, that how the muscles become weak. The pulse oximetry, which gives us the oxygen SaO2 oxygen level in the blood, and nasal and airflow episodes of apnea and hypopneas, and sleep position to some extent. If you lie down to the side, the obstruction becomes less, and so the snoring attacks come down. And check the blood pressure, esophageal pressure, the endoscopically, and as I told you, the polysomnography. This is the one which gives us correct indication of the level of the sleep. Okay? Stages 1, 2, 3, and 4, and the REM sleep. And electroencephalography and ECG is also monitored to see the changes that happen in the heart rate and also the rhythm. Then electrooculogram for rolling movements, eye movements, which are seen in the rapid eye REM sleep. So this is the gadget that is attached when the person is sleeping, which will record the various parameters, the blood oxygen, the breathing event, the REM sleep stage. So some graphs have been made available. Normal sleep study, usually the electrooculogram and ECG usually normal, and the oxygen saturation normal, more than 95 or 98%, and then the airflow is free, the thoracic muscles action, the abdominal movements, and the sound that is produced. Because of the obstruction and the vibration of the tongue, the soft tissues, the tongue and the soft palate. These are the ones which are monitored in a normal sleep study, and sleep studies done usually in labs. Sometimes they are conducted at home. And the obstructive apnea, complete cessation of airflow despite efforts to breathe. This is how the saturation comes down, desaturation. And the airflow, and the movement, if you see, there is total obstruction. And the thoracic muscle respiratory effort becomes less, and then the abdomen movement also comes down, and then sometimes totally stops. And this sound, they snore, and then suddenly there is a total stoppage of breathing, and then it starts again. So the pathophysiology cycle that we have gone through, this is monitored this way. And a central apnea, and this is how it happens, and we mix it. These are the various polysomnography studies, graphs, which give us the indication of about the level of gradation of the snoring. And this is for the hypopnea, where there is only partial obstruction. Now the management is usually by non-surgical methods, non-intervening non-surgical methods, which are, if there is obesity, weight reduction, the avoidance of alcohol, because sedatives and smoking, these are the ones which release the alcohol is the one which relaxes the muscle, and so there is collapse of the pharyngeal segment. And sedatives, of course, also do the same thing. And smoking produces hypertrophy of the tissues, and so can give rise to that. Then the positional therapy, patient is asked to sleep to the side. And there are some nasal devices, there are intraoral devices, there are mandible advancement devices, the tongue retention device, and CPAP. There is, we'll see. This is how the nasal cavity, the anterior nares, and this is the process that is inserted into the anterior nares there, and so it widens that, and so there is increased airflow. These are the nasal clips that are present in order to reduce the obstruction in the nasal cavity. Then reducing the obstruction. This is how obstruction in the oropharyngeal region. This is the major cause, and so as I told you, the tongue is attached to the mandible, and so these are the processes, dental oral process appliances, which pull the mandible forwards. They pull the mandible forwards, thereby pulling the tongue forwards, and so thereby the collapse of the tongue doesn't take place, and so the oropharyngeal or pharyngeal the region, there is a increased space. So these devices help in increasing the space in the oropharyngeal region. They are called the oral appliances. Then you have the CPAP is the one wherein there is a positive pressure that is applied into the nasal cavity, which do not allow the soft tissues to collapse, and so thereby there is a small pressure gradient, and so the air flows into the larynx and then into the lungs. That is about the appliances that are present non-surgical procedure. Then management of surgical by surgical methods is wherever there is obstruction, you will deviate septum, hypertrophy of the turbinates. You just have to do surgeries to reduce that, and if there are polyps, removal of the polyps, and any tumors, remove nasopharynx, the adenoids, particularly in children, and then you come to the tonsils, tonsillar hypertrophy. You do a tonsil resection. The tongue, there are certain procedures which are there to reduce the tongue size, particularly by the radio frequency or the lasers, and some of the osteotomies, mandibular osteotomy, genioglossalal advancements. This briefly I'll tell you about these procedures. Now, the most standard procedure that has evolved and has given good results is the remove the tissues, hypertrophied tissues. That is, you excise the soft palate along with the uvula, and the tonsils are removed, and then ultimately it is sutured like that. And so the oropharyngeal isthmus is the one which is widened here. Okay, so this is done for those people, as you have seen, the hypertrophy. Yeah, hypertrophy. This is the area. This is how it is removed, and so that opens up the oropharyngeal. This is called uvulopalatopharyngoplasty. Uvulopalatopharyngoplasty. Now, this is a procedure which is become quite popular, and that is as far as the oropharyngeal region. And sometimes, if there is macroglossia and there is hypertrophy of the base of the tongue, you do the laser excision or the radio frequency, and sometimes the glossectomy to reduce the size of the tongue, and the palatal somnoplasty also to reduce the soft palate region. Then there are certain methods wherein you enlarge the bony space by surgeries, like the mandible. There is a small window that is made where the genial tubercles are attached, and pull the entire that part of the segment anteriorly, so that the geniohyoid and the genioglossus muscle are the ones which are pulled forwards, and so there is space that is created in the oropharynx, and that reduces the soft tissue collapse and gives you the relief. And there is hyoid myotomy with suspension. This is the hyoid bone, and that's thyroid cartilage, how it is done, so that once again the space in the oropharyngeal region is increased, and so gives rise to reduction in the snoring, sleep obstruction. Then ultimately in patients who have multiple levels of obstruction, right from the nose, the nasopharynx, the soft palate region, the oropharynx pharyngeal region, the epiglottis, the hypertrophic tissues, and short neck and bulky obesity. In such people, you cannot be performing so many surgeries, and so the gold standard procedure is to bypass all these by doing a tracheostomy, and the patient will be breathing through the tracheostomy opening, and the obstruction is relieved there. So this is usually done in people who have obstruction at the multiple levels, a short neck and obese people where there is high risk of cardiac arrest, and so the tracheostomy is a single procedure wherein you bypass all these obstruction levels and then give rise to the air flowing freely. Every procedure has got its own plus advantages and disadvantages. You just have to weigh between the advantages and disadvantages, and since the procedures are life-saving, you may have to do a tracheostomy, which is called as the gold standard procedure. Thank you. And just go through these pictures once again and see what is normal sleep, non-REM sleep, and the REM sleep. And the duration is 75% is the non-REM sleep and 25% is the REM sleep. And the non-REM sleep, your stages 1, 2, 3, 4, and the third or fourth stage where there is total relaxation of the muscles, voluntary muscles, and so abstraction, and that is the one. Now, before we close this session, I would request all the students to pay the whatever is the fee, and at the earliest, without going into late fee situation and problems thereby, I would request all the students to pay the fee immediately at the earliest. Thank you.